Hey everybody, thanks for tuning into Module 7 on Conduction Blocks, part of our EKG Fundamental series. Learning objectives for this module, we're going to be able to compare and contrast the types of atrioventricular or AV blocks and be able to recognize them in EKG strips. We're also going to be able to recognize patterns associated with right bundle branch block and left bundle branch block. Let's review the normal conduction system of the heart. In a normal heart, signals start in the SA node, the sinoatrial node, go down to the AV node, then down the bundle of His, or His' bundle, bifurcate into the left and right bundle branches. The left bundle branch has two additional branches, but eventually both the left and right bundle branches become Purkinje fibers. Now what if we had some kind of damage or pathology occurring at the AV node or even at the bundle of His? In such a case, the heart can develop what is called an AV block or an atrioventricular block. And there are various types of these. We're going to go over each one of them. If there was damage to the left bundle branch, we can develop what is called a left bundle branch block. And similarly, if there was damage to the right bundle branch, we can develop a right bundle branch block. There are four types of AV blocks you need to be able to recognize. Those are the first degree, the second degree type 1, the second degree type 2, and finally the third degree. We're going to go through all of these in this video. Let's start with AV block first degree. Remember that this is an issue occurring somewhere in the AV node or the bundle of His just below it. When assessing for any type of AV block, you want to look at the relationship between the P wave and the QRS complex, because it is between those two that conduction through the AV node occurs. In a first degree AV block, there is prolongation of the PR interval. In other words, the PR interval is greater than 0.2 seconds, or 5 little boxes, or simply one big box. This is fairly easy to recognize, and we'll look at an EKG showing a first degree AV block in just a moment. What about a second degree type 1 AV block, or sometimes called a Wenke block? In such an EKG, we would expect the PR interval increasing with each beat until it reaches a point where the AV node conduction doesn't even occur and the beat is dropped. This is what it would look like. We would have a P wave, a QRS complex, a T wave, another P wave, but this time the PR interval is slightly prolonged, a QRS complex, and then a T wave, another P wave with an even more prolonged PR interval, QRS complex, a T wave, and then another P wave, but this time the AV node conduction doesn't happen, so you don't see a QRS complex. Once again, in a second degree type 1 heart block, we would expect to see PR prolongation that's increasing with each beat until eventually AV conduction doesn't even occur and the beat is dropped. We'll see an example of this as well. What about a second degree type 2? In this case, we do have P waves that conduct to form QRS complexes and other P waves that conduct that don't form QRS complexes because of AV dissociation. But unlike the second degree type 1, there is no regularity to this pattern. It would look something like this. So you would have a P wave, QRS complex, T wave, another P wave, but this time nothing following it because there's no conduction through the AV node. Another P wave with a normal QRS and then a T, another P wave, normal QRS, then a T, another P wave, this time nothing conducts, etc. There is no regularity to this pattern at all, unlike in second degree type 1. Next is the complete heart block, also known as the third degree AV block. In this case, there is complete AV dissociation. So complete AV dissociation. That means the SA node can't talk to the AV node at all. For this reason, you'll see P waves, or the SA node conduction, marching at its own consistent regular rate. And then on top of that, we would see QRS complexes marching at their own rate with no association between the P waves and the QRS complexes. And we'll see an EKG showing this as well. Okay, now it's the left bundle branch block. One thing I want to emphasize is that there are unique criteria that must be met in order to determine if an EKG has a left or a right bundle branch block. For the sake of keeping things simple, I'm just going to refer to general rules that'll help you identify these left and right bundle branch blocks. But keep in mind that there are specific criteria out there in order to define these much more clearly. As the name suggests, this is a block of the left bundle branch. Because the left bundle branch is blocked, the right side of the heart will depolarize earlier than the left side of the heart. And for this reason, we would expect to see a wide complex. In other words, a prolonged QRS complex, or a QRS complex that's greater than 120 seconds. The other key feature of a left bundle branch block is to see a very deep S wave, especially in V2 and V3. And we'll look at an EKG showing this. Okay, now we talk about right bundle branch blocks. Once again, I want to remind you that there are specific criteria out there defining a right bundle branch block. We're just trying to keep things simple to make it easier for us to interpret the vast majority of EKGs. Once again, it is the right bundle branch that is blocked. Because there is slower conduction through the right bundle branch than the left bundle branch, we would expect to see a prolonged QRS complex, or a wide complex. The second feature we would expect to see is what's called an RSR prime pattern. It looks something like this, RSR prime pattern, usually in leads V1 to V3. Sometimes this is referred to as rabbit ears, because they look like rabbit ears. And we'll look at EKGs showing this as well. Okay, take a moment, pause the video, and see if you can identify any blocks in this specific EKG. Alright, so if you looked at the PR intervals, they are totally normal. They are less than one big box, and there's no dropping of any beats, so there is no AV block. You will notice that the QRS complex is slightly prolonged. It's most noticeable in lead 1 and also in V1 through V3. Finally, you can actually see the RSR prime complexes in leads V1, V2, and V3. The combination of a prolonged QRS complex and the RSR prime pattern seen in these precordial leads suggests that there is a right bundle branch block. Let's look at this next one. Take a minute to pause the video and identify the block. Alright, so once again you'll notice that there is no PR prolongation. In fact, it's just about 5 big boxes. There is, however, widening of the QRS complex greater than 3 little blocks. You can see that in lead 1, as well as most of these precordial leads as well. Finally, you see very deep S waves in V1, V2, and even V3. All of these are suggestive of a left bundle branch block. Pause the video and try this one out. Okay, so we've actually seen this EKG before. If you're paying attention to the PR interval, you will notice that it is prolonged. For example, the one over here, PR interval starts here and then ends here. It is greater than 5 boxes, 5 little boxes. It's almost 6 to 7 little boxes. This stays pretty consistent and there are no dropping of beats, so this is likely a first degree heart block. What about this one? Pause the video and try to identify what's going on. Okay, let's see what's happening here. There's a very strange pattern. You'll notice that the PR interval here is within normal limits, but see what happens to the next PR interval. It gets a little prolonged, and the next one gets even more prolonged. This one here gets even more prolonged, until you'll notice here that this P wave here right after this T wave doesn't even conduct. There's no QRS complex here. Once again, here we have a P wave with a normal PR interval. It gets longer again, it gets longer again, gets longer again, until it just drops with no QRS complex. This prolonging of the PR interval until a beat is dropped is called a second degree type 1 heart block, or a Wenckebach. What do you guys think about this one? Take a moment and try it out. Alright, let's see what's happening. We have a P wave here with no QRS complex here. We have a P wave here that's conducting to form a QRS complex. We have a P wave here that's conducting to form a QRS complex. We have a P wave here conducting to form a QRS complex, all with normal PR intervals. But once again, this P wave conducts, but the beat is dropped. Following this, a P wave conducts normally to form QRS complexes. Because of the lack of the subsequent PR prolongation and the erratic nature of the beat drop, we're going to call this a second degree type 2 heart block. Alright, take a minute and look at these two EKG strips and try to identify what's going on. Let's look at the top one first. We do have P waves, and the P waves are conducting at a given rate. We also have QRS complexes, and the QRS complexes are conducting at their own regular rate. There is no association with the P wave and the QRS. For example, this is not a PQRS complex right here. This P wave is not conducting down to form this QRS complex or depolarize this ventricle. In fact, this QRS complex, due to its wide nature, is most likely what's called a ventricular escape rhythm, meaning that the ventricles can't see any P waves coming at them, so they're just going to fire at their own slow rate. So we would call this a third degree or complete heart block with ventricular escape rhythm. Let's look at the one in the bottom. Again, we have these P waves firing at their own rate. Notice how this P wave is hidden within the T wave. But we do have these P waves firing at their own rate. And we also have QRS complexes firing at their own consistent rate. Even though it looks like there may be some association between P waves and QRS complexes, there aren't, because they're both firing at their own rate, independent of one another. This is also a third degree heart block. But in this case, because the complexes are narrow, this is likely a junctional rhythm, meaning that the AV node or the area around the AV node starts conducting autonomously at this given rate, with no signals coming in from the SA node. Okay, the takeaways for this video. The heart conducts from the SA node to the AV node to the bundle of His to the bundle branches, eventually to the Purkinje fiber, with varying innate firing rates at each level. Abnormalities in conducting system can result in various types of heart block. We understand the difference in EKG findings between the different types of AV block, and we also understand the general features of left bundle branch and right bundle branch blocks, keeping in mind that they do have formal definitions and criteria that must be met to officially claim that these blocks are present in a given EKG. That's it for this video. I'll see you in the next one on structural abnormalities.